All right, so we're good to go, Elizabeth. Okay, so Dr. Mintz asked me to talk about the management of the complicated diabetic foot from a wound perspective. So in trying to think about, as a former primary care provider, what that really means, I wanted to start with this referral because really, in my mind, taking care of a diabetic patient with ulcers, with complications, really is a multidisciplinary approach, which is, also Dr. Mintz's premise for this group and how we all have our different areas that we work together. And it really does take a multidisciplinary approach to handle these patients. Sometimes in the rural areas, it's hard, as you guys are well familiar, getting your patients to all the different providers. And sometimes as a primary caregiver, you take on some more of these responsibilities for patients that don't go. But I just mentioned here, and obviously these there may be other specialties, but these four specialty groups, I feel are common core when dealing with these difficult patients from a structural and surgical standpoint. So vascular surgery for the ability to revascularize and provide more oxygen to the wounds, wound care for frequency of appointments, advanced dressings, advanced care for larger, more complicated wounds, podiatry for, there's a lot of surgical intervention that may need to occur related to these type of wounds, and footwear and offloading, infectious disease, since these more multi-drug and even resistant infections become complicated in these patients as well. I didn't list things like endocrinology. I mean, obviously diabetics, primary care, endocrinology, meaning the diabetes, but we're really talking about dealing with the wounds and the complications thereof. I kind of went with these four main groups here. So we can go to the next slide. So I kind of lumped in what kind of complications do we see. So these are the four areas with wound types related to these four main topics is what I decided to focus on. So we'll kind of go through the Charcot foot, the wounds with gas gangrene, osteomyelitis, and a diabetic foot ulcer in patients with critical limb ischemia or PAD. And I wanted to try to focus on kind of the signs and symptoms that you may see with patients coming in with these more advanced problems if they don't present early on, or if you are managing kind of your basic foot ulcer in your clinics and all of a sudden it turns and goes bad, what you may see and how you can work it up and eventually get the patients to the appropriate specialty clinics. Okay, next slide. So the first we'll talk about is Charcot foot or Charcot arthropathy, and I've included on all these slides the ICD-10s. And the reason I do that is in wound care, this is very, very important for documentation, reimbursement for supplies, for ordering your offloading shoes. And so sometimes that's something that's not really stressed as much through training and our reliance on electronics anymore and what's built into our EMR and getting it correct. But I just kind of wanted, you'll see those through here in red, but those become very important to us, particularly in advanced wound care when doing some advanced dressings and getting authorizations for skin grafting and patient supplies as well. So, and I wanted to include them in case from my other lecture you guys were attempting to use any of those companies. Some of these codes will help you there. Next slide. So I know we had a more in-depth lecture on Charcot foot, but this is the acute Charcot foot, and some of the signs and symptoms your patients may present is with a severe pain, skin discoloration, and swelling. And I think it's real important to, as Dr. Mintz stressed, to feet inspection in these patients. As you can see, there is the classic rocker bottom foot, and distinguishing cellulitis from a Charcot flare can sometimes not be the easiest to distinguish, and many can look red and hot. The other symptom you may see in just examining the patient's foot are just changes in the shape of their toes and ankles. And then eventually, because of these mechanical stressors and the fractures that occur in the midfoot from chronic neuropathy and microvascular disease can lead to ulcerations. So those are all kind of things you may see in the presentation of this complication. Next slide. So how do we treat it? Here's an example of bilateral plantar diabetic foot ulcers in a patient with Charcot. So I started with offloading because it's very important in these patients, and it can be difficult. You can see the misshapen foot is to get pressure off these wounds. It's also important to have the patients inspect their feet every day and also washing and moisturizing. And the reason that is important, there's going to be a lot of hyperkeratotic skin buildup, dry skin that can increase their risk for infection. So making sure that they're cleansing their feet, moisturizing is also important in reducing ulcerations and care. Regular diabetic nail care through podiatry, we try to encourage the patients we see to make sure if they aren't doing that, that they are, and not to try to trim their nails themselves. When patients are like this, referring them to podiatry or advanced wound care at this stage, can be helpful. Serial debridements, routine wound care, whether it be with some of the stuff we talked about it last time I spoke, Santal, Metahoney, and dressings. And then there's also surgical options. I think Dr. Hurst kind of touched on, so I throw that out. So there's lots of various treatments with that. Next slide. So when I talk about offloading for Charcot, this is a crow boot. And this is something you can order, and I kind of wanted to just make it real simple on how you would order it, putting it on a prescription in order for the patient where they can be custom molded. This type of boot will offload their weight more around the ankle and less on the foot. And a lot of times it really helps reduce some of the pain associated with the instability of the foot in Charcot. And again, I've included the ICD-10 diagnosis codes because those can all be very important. And when we order a crow boot, we will put all three of these on the prescription. Similar when ordering diabetic shoes, you want to have an ulcer or pre-ulcerative gout. You have to have a reason other than just diabetes. If you have patients with this, this is exactly how you can order a crow boot, to get it covered. Okay, next slide. This is another type of treatment that can be done in podiatry practice or an advanced wound care clinic, and this is called the Total Contact Easy. It's a weekly cast, so it also offloads the foot completely. So the weight is, when patients are weight bearing, their weight is at the ankle. I guess the downside would be is it does require weekly visits. You also have to, if it's wounds on the right foot, we have to consider driving. They can't really drive. So those are things to consider, but it does, we use this in a lot of our Charcot patients as well, that are good candidates. If they have good balance and stuff, it can actually, ambulate fairly decently. We'll offer them a Total Contact Easy, and it's a nice way to promote wound healing. Next slide. So the second complication is one of more serious nature, is gas gangrene. And that, again, the ICD-10 code. And next slide. So early detection and recognition in this can be critical for the amount of damage, because this is a type of problem that is caused by a Clostridium perfringens organism or any other soil-borne anaerobe, and it can cause rapid myonecrosis. So on the right is actually a picture of Dr. Suchak. I let her know it was a mutual patient we had, but this kind of shows these blood blistery lesions. The foot is a little shiny. Sometimes the foot can blow up just like it might look like a water balloon. So if you see kind of that tightness in the skin with these blistering lesions that look like blood blisters in a diabetic, that's definitely something that you want to consider and make sure you don't miss. If they are having drainage, it often has putting foul and sweet together, but there is a very characteristic malodor associated with these wounds. It's also very painful, and they're usually sick. They're going to have a fever and some other constitutional symptoms. If you're not sure, it's going to be something you order an X-ray. If you look on the left, this is kind of shows the classic subcutaneous emphysema from the gas-producing organisms here around the fifth metatarsal head and phalanges there. You can kind of see the air in the soft tissue. This is a thing that you want to get to your podiatry colleagues or the emergency room. They need surgery in a timely fashion.
Can I add, like, if I could put the Hot Foot Hotline phone number right there, that's where I would put it. That's, you call us, we get them to emergency room. This is hours, not days waiting.
Yes. Yeah, and then recognizing the sign really early, as was mentioned in one lecture, these infections can start to get into the foot and track quickly up the fascial planes. So something that just looks like it can start in the toe, in the end, can lead to be a much larger dissection, and we'll see a little bit of that on the next slide, please. So this is a picture. So we talk about treatment, early recognition, IV antibiotics, and surgical intervention. This was a patient, actually, this was from a patient that Dr. Kane and I had actually during COVID. He kind of presented. I could smell him before I walked into the room. His foot was a water balloon, and with light touch, it ruptured like a bad abscess, and it was pretty significant. It's kind of amazing, actually, how well the foot was saved, and we're still taking care of him today. But Dr. Kane did a wonderful job saving this man's foot. He never had a significant amputation. But you can see where, and I don't have the slide in here, the bottom of his foot did look, the whole foot looked like a water balloon, and you really only had some callus of his foot and a small opening. So, but you can see when he got in there where all of the infection was. Next slide. And this is the same man's foot from the dorsal view. So you can see how much debridement and cleaning out the podiatry had to do just for what appeared to be a small plantar diabetic foot ulcer, but because it got infected with anaerobic Clostridium and causing the gas gangrene, how much more devastation to the foot there was. Now we can see tendon exposed here. So when we have kind of these deeper and extensive type of wounds, one of the things that is often done with the infection is cleared is skin substitute grafting. And there's various products that can be placed intraoperatively or in the clinic. This gentleman got intraoperative Theraskin, which is cadaver skin, and he did very well. This man would require, I put advanced wound care as post-acute treatment because this is going to require a lot of frequent visits, reassessing, making sure, because of this large surface area, that he's being managed pretty closely. The other option I put on here is hyperbaric oxygen therapy, just for us to think about and realize that gas gangrene is one of those things that can be referred to. Maybe not be an option in your rural area because of the driving commitment, but it's just something to at least keep in mind. Next slide. So we go to something maybe a little bit more common, which is osteomyelitis or infection of the bone. Fine. Sorry. Okay. So how do we recognize common signs of osteomyelitis? When I found this patient, this was a real good classic example of the sausage toe. These are the patients that are come in where the signal being swollen, painful toe. There may be malodorous discharge. So those are some of the common things. Sometimes they don't have the malodorous discharge, they just have pain. It depends on what part of the continuum, but when we see kind of these sausage toes, you want to think about it, and we have an ulcer with a sausage toe, so we want to obtain diagnostics. So you go to the next slide. So here's an x-ray of a different patient, but I thought we don't need a radiologist to see the destruction of the great toe and the second toe distal BIP joint. So the bone infection can destroy the complete toe. Sometimes it's more subtle. This showed complete destruction, and this patient, unfortunately, because of the great toe there, had a partial toe amputation of the right, or amputation of the right toe because that bone is not going to grow back together. Some of the common workup that I do when I see a stable patient in my clinic with this is I'll often do an x-ray first and combine it with a 3 lab test here. The reason is these x-ray findings, depending on how long the patient has had symptoms, the x-ray findings may not be definitive right away and can lag behind. So if I would have a patient and the inflammatory markers of the labs are elevated and the x-ray doesn't really show it, I still may treat or refer to infectious disease and go for a more definitive study, such as an MRI or a white blood cell tag nuclear scan may also give you more definitive confirmation there. But that's kind of the classic x-ray findings that you would see, is just destruction, cortical bone loss, and like I said here, even complete annihilation of the DIP. Next slide. Okay, so how do we treat it? Obviously, you want 6 weeks of antibiotic therapy, IV. I treat some PO as well, depending on how advanced it looks. You know, if the patient's stable. If I treat them orally, often I'm going to use a quinolone because it penetrates bone the best. But there are some of your augmentins and doxycycline, so there are some options there. But infectious disease is also an option in these patients because they're high risk to get them involved as well. Advanced wound care, we have non-viable tissue here that you can see, sort of the black non-viable tissue. And so while the antibiotics are working the infection, we still want to take care of the wound. So using a Santal or Metahoney as an agent to kind of get rid of your non-viable tissue and get down to good tissue, as well as absorptive dressings will help. Hyperbaric oxygen therapy is also an indication after the acute phase is over. So what that means is chronic osteomyelitis is an ICD-10 code and approved diagnosis for hyperbaric oxygen therapy. And those patients who have completed their 6 weeks of antibiotics and have diagnostics confirming osteomyelitis could be considered for HBO referral as well. And then obviously amputation. An option there. So our last one that I want to talk about is a diabetic foot or toe with ulcers in a PAD patient. And those are our 2 diagnoses there. Okay, so obviously diabetes and PAD are very common and run together. And depending on what part of the severity continuum each of these are at, you can get different signs and symptoms. But typically, you'll see sometimes early signs of PAD in a diabetic foot are just going to be fissures. Diabetics with neuropathy often have dry feet and cracked heels. So kind of trying to delineate what fissures may be an early ulceration associated with PAD. But I just wanted you to keep it in mind when you see these fissures. Some of the common places you'll get them are on the heel there. You can see a small one. Lateral and medial heel are often a very common place we see these fissures. Typically, the classic signs are dependent rubor. So when this patient's leg is down, it tends to be red to purple. You elevate it, and it becomes pale, often associated with pain with elevation. Claudication, that's pain with ambulation. You know, a lot of these PAD patients have some degree of claudication, and knowing what's severe, that's also kind of what you can use the hot phone hotline for. Diminished absent pulses. As the limb ischemia gets more critical towards acute, you're going to start to have impaired motor sensory function, so you're going to have impaired walking function as well. I didn't put the diminished hair, but that's a sign. Rest pain, pain waking them up at night, more of a sign that you've probably got more severe disease. And then non-healing wounds. Again, the medial and lateral met heads, so your first met head there by the big toe, and the opposite side, those are common areas we'll see along the lateral foot, usually the malleolar regions and the medial and lateral parts of the heel. Common anatomical locations you'll find ischemic ulcers in addition to the toes. Next slide. How do we treat these? Obviously, you have a lot of non-viable tissue due to lack of oxygen, so Santal, Metahoney, and absorption. We do debridements. Some of these cases, I will use betadine on a stable dry eschar if they're immediately awaiting vascular intervention. But if they have good blood flow, we're working actively and aggressively to get their wound healed with our ointments, absorption, and debridements. Antibiotics can be a consideration too if you feel there's a concomitant infection involved, but revascularization is the big thing. That's going to give you, that's what's going to save the limb. That's what's going to turn these wounds around. You can do all this wound care, but it's not enough oxygen. Then obviously amputation usually is the last resort with these patients. Next slide. Before I show you some before and afters with these patients, I just wanted to throw this slide in because a lot of dealing with these two diseases in patients starts with your prevention. So your ongoing smoking cessation with these patients, the antihypertensive therapies, controlling their cholesterol with statins, controlling their blood pressure, antiplatelet therapy, cilostazol and pentoxifylline in your claudicants, and a structured walking program. So this is just really, all these things, these patients aren't just coming in at once, you're seeing them multiple times, and these are all things to think about that need to go on as well with your patient. That as a primary care, you can, be doing a lot of anticipatory guidance for ensuring that these things are being taken care of, because they're going to help to ensure the best medical optimization for your patient, the best chance at limb preservation. Okay, next slide. So our diagnostics when dealing with PAD and a diabetic foot ulcer is our PVR, our arterial duplex, and then eventually a CT angiogram are all some of the more advanced studies to help you determine, is there enough flow? Do they need revascularization? Do they need referral to vascular surgery? Is it so this is just an example of a pulse volume recording, but you can see if you look towards the bottom where we have some flat line at the toe across the metatarsals. This is an abnormal study. And so if they have wounds on the feet, and with an abnormal study like this, I would be referring to vascular surgery to have them evaluated for the potential for revascularization options. So we know whether there's a chance at healing these wounds or not. Okay, next slide. So to kind of finish up, I want to show you one patient that was referred to us. This patient had a TMA. He had diabetes and PAD, but kind of came in and presented with a new ulceration, was in severe pain, kind of writhing out of the chair. So if you look on the left, where this was before revascularization, I know our clinic pictures sometimes aren't the best because of the lighting, but there was definitely dependent rubor here. His pain was significant. We did vascular studies. They were abnormal. He was referred to vascular surgery pretty quickly. Revascularization was done, and in 4 months, you could see that he had a healed wound. Some of that is, this picture was taken before just the callus was shaved off, but everything is fully epithelialized under there. So, we treated during the whole time that he was getting revascularized. We're still treating the wound, but you can just see the difference in the skin, the peri-wound skin, once oxygen and blood flow is restored. Next slide. So this is the same patient, and I want to show that this is the lateral foot. Like I said, you'll see ischemic ulcers, diabetic foot ulcers in this location. The one on the left was before revascularization. You can see almost the purplish dependent rubor there. Again, pain, non-viable tissue, 3 months after he was completely healed. Again, that slide here. So it just shows you like how quickly and often within the first few days to week the skin changes, improve. Next slide. And this is the medial heel. And again, the one on the right is healed. It's not the best sign. It was kind of wet. The patient didn't had some Telfa on with this. So, but it just shows you that it may take a few months after, even with these size. But with the patient would come in every 2 weeks, receive wound care, serial debridements, post revascularization, and healed all 3 of those wounds and saved amputation. I think that might be it.
Thank you so very much, Dr. Diamond. That was a wonderful presentation, very informative. Does anybody have any questions or comments?
Thank you for letting me participate.
This is great. Would love to hear if anybody else in the group has anything that they would like to add to from our primary providers. Are there, are you seeing, do you see these kind of feeds? And is this information, are you trying to manage some of this stuff on your own?
Fortunately, I have not seen any feet like that, but it's very good information to have for when I do. I'm sure that it's inevitable at some point in time.
I wanted to add just a footnote to Dr. Diamond's comment about the crow boot is that it would those cannot be molded if a patient has a wound. So the prescription would probably make more sense to come out of a podiatrist's office versus you guys. But certainly you can refer to us for something like that. And that's just to make sure that the patient has complete information about what a crow boot does and that they currently don't have any open wounds, because generally they can't be molded if they have any open wounds on their feet. So
Yeah, I don't know. I've ordered some, Catherine, and they've made them. So I can think of one patient actually, I think, having surgery with Dr. Monty, but had.
Yeah, that's interesting. Generally, the rule is because
I know that
be
even with the diabetic shoes, that there's similar problem, but we definitely at some point, if we're casting them and getting them into something, and then maybe that was like a rarity. I don't know. Maybe they made an exception. I have no idea.
Yeah, sometimes it depends on the size of the wound and, is it almost healed or is it, this gigantic wound? It probably depends, but yeah.
Our podiatry colleagues down in Pocahontas area, do you have success getting your patients crow boots and things like that? I don't know, Dr. Hurst or it looks like Dr. Michael had to hop off, but if you had any comments on how easy it is to get those kind of boots.
I've yet to order one, but usually I just have Kirk do it all. So, in all honesty, he'll do my like pro boot versus double upright and things like that. So, but I have yet to have to order one.
Okay. Well, that's good. And you all are still getting access to Kirk at Marlinton? Good. Are the patients wearing the shoes that they're getting from him?
Yeah, in my experience, patients are wearing them, and for the most part, they love them. So
love them.
There's a few outliers that don't care for them, but
that's great. That's good. I forget who we were talking to this about, but some of them are like actual work boots, right?
Yeah, I think I was telling you that one of my patients has like a work boot, and he likes it. Mm-hmm.
That's interesting. Maybe more successful in getting our rural patients to wear these because they have that versus some folks that want like nice loafers.
I mean, that's the reality is, we're in West Virginia and I go to PA, you've got a lot of coal miners. And many times, even if you're getting them, I always tell them diabetic shoes are not like the diabetic shoes of old and the thick black platform shoes that no one wants to wear, kind of identifies them. They have sneakers, they have loafers, and many of them, can even have a custom insert that will go into their metatarsal, because we get a lot of those, coal miners that have to wear a metatarsal boot. So I think just making the referral, a lot of these orthotists are great at, crafting something that's going to work with their lifestyle.
That's great. All right. Any other comments? Like that was helpful. I love the codes. That was really great. Our little coding cheat sheet that you provide, I think is really helpful. And that that hot foot that you showed was definitely, it reminded me because Dr. Kane and I just took care of a patient last week, I think, that came in with a necrotizing foot, and it inspired me to collect some of those pictures so that we can have that for a presentation later. I think you're taking him to the OR today again or something, Dr. Kane? He's just sneaking around in his chart.
No, I was just, I thought he was coming in my clinic soon. I can't remember. I was trying to think about that. I was talking to Jake about that today, and I couldn't even remember my call week was a little busy. I couldn't remember exactly what I was doing with that guy.
Yeah, it looks like they scanned in a bunch of consent and surgery consent forms today.
I scanned him in. I took him twice though. I took him the
Yeah.
day from the ED that you called me.
Yeah,
I had him in the OR within like a couple hours.
you did. It was awesome. Well, once we kind of get more of a complete course on him, we can present it.
Yeah, and then I took him back, debrided him, and then I put a wound vac on him. He ended up losing his fourth and fifth toes. I think he did fourth and fifth ray amputation, and then but he still has a foot.
Yeah, so far so good.
Yeah. So.
All right. All right. So do we want to present Kristen's cases?
Yeah, absolutely. Kristen,
Great.
are you ready? I can share them.
Yeah, go ahead. I have them printed out here too, so.
Excellent. This is the 89-year-old patient. Is that okay to start with that one?
That's fine with me.
Oh, why don't we do the other one just
Okay.
because that one's already done. This one might actually have more questions.
Okay.
Okay, so I've got an 81-year-old male, very chronically ill. This is one of my home visit patients. He's got a medical history of atrial fibrillation, coronary arteriosclerosis. He's had CABG, multiple MIs in the past. He's had a history of osteomyelitis and gangrene to one of the toes on his right foot. He's obviously got peripheral arterial occlusive disease, hyperlipidemia, and he's a smoker, of course. So this is a guy that he was just discharged from the nursing home probably about 2 months ago. I saw him on a home visit and he had this it looked like a blood blister, like a pressure ulcer to his right heel. So we were just kind of keeping an eye on that, offloading pressure. I told the wife to let me know if it opened up or anything like that. He has a home health wound care nurse coming in. So I hadn't heard anything for almost 2 months. And we just saw him last week and he's got this necrotic eschar that's over top of this wound now. And the wife was saying that they have been using it's Zeroform and then wrapping it with gauze. So it's kind of staying moist. And so she said that she noticed some drainage from it, some purulent drainage. So I was obviously concerned for infection. So I did send him in an antibiotic and we referred him to the wound care up at PMH. So luckily that's only about 20 minutes from his house, so they could make it up there. The next day she called me and said his systolic blood pressure was like in the 70s. So I told her just to go to the ER, have them look at it. They ended up admitting him overnight. Did not really think that it was infected. The wound care provider saw him up there and recommended doing the betadine paints and leaving it open to air so it could dry out a little bit. So, and whenever I checked his pulses, they're very thready. We know he's got peripheral disease. He's seen vascular in the past. I don't think he's ever had any stents done from my knowledge. It was kind of hard to tell from the previous records, but I know he saw them back in 22 when he had this gangrene and osteomyelitis and all that. And they were doing the betadine paints to his toe, and eventually the toe just fell off. But I was just worried about, as far as access to care, he does need to see vascular, but the wife has said, it's really hard to get him to leave the house to go see a specialist, especially for us, it's driving probably 2 hours plus to get to a specialist. So I just didn't know what all we could do. I know he's been on, I'll probably butcher this, he's been on silostazol in the past, but he's just so hypotensive that he can't tolerate any type of medication like that. He's on Brilinta, he's on a statin, but I don't know what else that I can do from my standpoint.
Okay, it's a good case. Elizabeth, can you please keep that up there so we can keep looking at the Sorry.
And I don't have a picture of his wound, but if you want, I can take a picture. I'm going to see him today. So if you want me to like text you a picture or something, I can do that too.
That would be great.
Okay.
Definitely the heel ulcer kicks up the severity of
Mhm.
what might happen to him. And your heart rate being up. So this is when you saw him and you sent him to the ER already, correct?
Yeah, I mean, he goes in and out of AFib, so that was his heart rate, it can go up and down. I mean,
Okay.
he'd been struggling with some hypokalemia and all that too. So he's still smoking like a freight train. You can tell he's malnourished, like he's not eating appropriately. So
From the vascular perspective, obviously, we would like, I don't know, was he seen at Ruby or elsewhere?
oh, this was
Or
in
in
Virginia. I
WV?
think it was Centara is what the
Okay.
note said.
We might have access to those records, so, offline, maybe I can take a peek and see what he's had done. If has he had like an open surgery or a stent that we know of?
Not that I know of.
Okay. The Solostazole, don't worry about it. It's contraindicated in people with heart failure, so I wonder if there's a component there.
Yeah.
But that's really just to help people walk further without pain when they have vascular disease. I've seen it being used in wounds here and there, but I don't think there's any hard evidence for that. Just a baby aspirin and the Brilinta is plenty. The Torvastatin's great. We probably want to get an ABI. Maybe you can get that at PMH.
Yeah, we can do that. Mhm.
So why don't we add that and see what we're dealing with there, and I can review the notes for you to see what he's had done. I will now defer to my wound care and podiatry colleagues for next steps as far as the heel ulcer goes.
Yeah, Kristen, I would say, first of all, did you say he has home health?
He does, yeah.
Okay. So when you have home health, you can get access to more advanced dressings.
Mhm.
So if he has an open wound, I wouldn't betadine. It just is making it dry. It's going to drain. So, it's still open to risk infection. I would, this is not without being able to see the picture, but it sounds like he got some eschar, whether that's from pressure or he's got a blood flow issue. That's, where the ABIs will help you there. But irregardless, that non-viable tissue needs to go away. And if it was real wet, a lot of fibrin comes off these wounds and our patients think it is pus. I'm not saying it wasn't purulent, but sometimes we try to pin them down more to what it looks like. And that's why I'm wondering when he went up to PMH, they didn't think it was purulent, if it was fibrotic. So I don't really, I wouldn't personally recommend betadine on that. I would try to heal that ulcer. At minimum, I would probably put, if you don't have access, to Santal or MetaHoney. Some of the home health will get them MetaHoney. Santal, like I said, is prescription, or if that patient assistant program will get them free Santal for you. I put in my other lecture. But you could use something like, have them use like calcium alginate or is he have WVU home health? Do you know?
I want to say it's Home Care Plus.
Okay.
It's out
I
of
would say, because there's a one-time, some of our West Virginia home health, it's called Zetavit, but it's a super absorbent dressing with a silicone border, so they could either put an antibiotic ointment on the wound so you keep that moist wound bed, but the drainage goes into this more of a locked-in type of dressing, and it's one-stop shop. If that would be something you could order, honey or Santal with that, or a calcium out. Just tell them home health calcium, something on your wound bed, whether it's an antibiotic ointment, honey or Santal, then calcium alginate, and a border dressing.
Okay.
So that way you don't have to, actually, if they have home health, you don't have to technically order any dressing. You can just send your order to them, and they'll be able to get those advanced dressings for the patient.
Okay.
At least you then got drainage control while you're doing your workup to see if revascularization is an option. So irregardless whether this might be an ischemic, a diabetic, or even a pressure, you're still, because you're right, the gauze is just going to macerate it because it's not really absorptive.
No.
That would be my suggestion, just to kind of deal with,
Yeah.
Is he ambulatory?
A little bit.
Okay,
Yeah,
so
not a lot, but yeah. And I
able
was
to
thinking
do
to
heels.
Santal as well, so I'm glad that you said that. Sometimes I get kind of nervous to order that stuff, so because I don't do it often.
I think it depends on if he doesn't have flow, my sense is if they let the toe fall off,
Yeah.
yeah, then they probably did not have a satisfactory revascularization, and they were just like, either it'll fall off on its own and you're lucky, or a higher
Yeah.
amputation has to happen. So I would suspect that he may have non-reconstructible disease, but obviously we need to like prove that.
Right. Right.
So I wouldn't be surprised if he needs, a vascular to somehow get up to Morgantown for a procedure at some point, or at least get into the vascular clinic.
Mhm.
So we can kind of see what we can do for him.
The other thing I would add too is if he's not ambulatory and he's sitting around a lot, if that looks like a heel ulcer and it's a pressure point, I would try to show his wife how to aggressively offload that. If you're not able to get the like these little offloading boots, which some patients don't even like to tolerate them anyway, is use pillows and just aggressively offload the heel whenever he's sitting. Especially you kind of hinted that he's kind of has a thin body habitus, he's not
Yes.
eating, he probably doesn't have a lot of robust Q fat, and he's
No.
bony. So that's what I would do.
I might also want to add like a multivitamin and some Ensure to get some protein into him.
Okay.
Okay. Anybody else? That's great.
Yeah, that's very helpful.
Give us more cases. Let's get more like that.
They pop up randomly, so.
I know. It's helpful though. All right. I'm gonna pull up the other case. This is just I need you to re-enable screen share.
Yeah.
Or enable screen share.
You're fine, Dr. Reese.
Okay. Let's see where my slideshow is going to show up. Yep, that works. Now I just have to do that. Okay. All right, you got the main slide. All right, so this is quick. So this is an 89-year-old female that presented as a consult from Arlington with left leg pain and coldness. So her story was that she says she has a history of bilateral lower extremity pain that's been going on for a long time, but kind of going into December, it sounds like things got a lot worse, specifically on the left side. And then she's presenting with rest pain on that foot. So the pain is constant, day and night. It does get worse with activity. So there's some claudication type symptoms going on, but and it improves some with rest, but now this is constant on that left foot. No diabetes or tobacco use, and she's 89, so she's made it a long time without like terrible heart stuff. She does have some hypertension. She does have CKD. One of the things I thought was important to point out in this case is that she has a history of pelvic radiation from uterine cancer. And so there are some vascular risk factors to be aware of. One is just growing old is a health hazard. So you have older patients. And so if you have someone that's older, vascular disease should always be somewhere on the radar. But radiation causes accelerated arteriosclerosis. It causes fibrosis of vessels. And so as soon as you hear someone had pelvic radiation, you should kind of have the hackles raised that, oh, there may be some iliac disease or occlusion from that. Maybe. Often these are, this happens when they're younger. And so you'll have like a 40-year-old come in with all of a sudden occlusion. But it's something to think about. She was motor intact. And so the sequence of events is that she was seen in December. The ABIs were ordered at PMH. They were done in January. She came into my clinic in February. Her ABIs were severely abnormal, so left side is 0.26. That's actually critically abnormal. And I was honestly surprised that she had made it as long as she did. So this is probably, a very chronic thing. But somebody like that, and on exam, she doesn't have a femoral pulse on that left side. She had monophasic signals only. So definitely someone that, again, could be a hot foot hotline person if you wanted to, or just if you have a patient like this that you're really worried about, And I know we didn't have the ABIs till January, so I think we got her in as soon as we could, but I saw her in clinic February 2nd. I got her to the OR the next week. So here I circled it, but there was occlusion of the left iliac at the common, got across it, we're able to reestablish flow, and she ends up with a stent. So that's her story. But I think, some of the main teaching points there is, if there's no pulse and there's a pulse on the other side, trust yourself. If you can get the wand, take a listen. And I think one thing for our providers to do is that if you have a normal pulse on one side, listen to that with the Doppler and compare it to the other side, and you'll notice a significant difference. That's good enough for me at this point. Like, just send them, we'll figure it out. But yeah, we do have to get ABIs often before we can take them to the OR. But if you have someone that you're very suspicious about, we can try to move things around or make things happen sooner to get an ABI and a visit. So definitely something to consider. So that's that patient. And I did want to share when she was talking about the hot foot. This is one we had 2 weeks ago that Dr. Kane and I took care of. But can you just like feel the heat coming off of it from the screen? Like they called me and they're like, hey, we have this patient. And I just looked at the picture of the chart and I was like, ooh, okay. All right, this has to get taken care of. So anyways, just wanted to share that picture. We'll update you all on that at a different time. So any thoughts on that case or comments?
I will say too, whenever I started, I don't know, it was about 2 years ago, that patient, she had already been treated for sciatica pain, left sciatica, for several years, and she was on Lyrica, and she just kept coming back saying like, just my leg's just really hurting, and it doesn't matter if I take the Lyrica or not. So for one thing, I wasn't, she had pulses from what I could tell. I don't check femoral, I'll be honest, but I was like, well, I wasn't even thinking about the vascular aspect. And then, we were kind of focusing on her osteoporosis. So like, maybe it's arthritis, so we did the Prolia injections, all that. It wasn't until December when she was like, my leg's cold and I can't warm it up. I was like, oh, like let's get an ABI, like, let's see what's going on. So really that's, I know that's going to improve her quality of life a lot because she's lost a lot of sleep, because of her leg pain. So
I really hope so.
Yeah.
She's such a nice lady. She
I
does
love
not look
her.
89, that's for sure.
Mhm.
The other thing, she also has varicose veins, right?
Yeah.
So two things can't be true. But this one in this case is not from her varicose veins.
Mhm.
And they're impressive looking varicose veins. So
Yeah,
I
they
can
were.
definitely see that as being like, okay, oh, this is varicose veins, this is something else. And I don't envy you guys because there's such a differential you have to think of. For me, if they walk in my office, like, it's perfectly acceptable for me to take a patient to an angiogram as my number one diagnosis almost immediately. But you guys do have to work out through all these other things and the sciatic pain and everything else. So I don't envy you that. All right. Any other questions or any patients coming to people's minds they wanted to talk about? Okay. All right. What do we have on for next month?
Can you guys hear me? All right. Looks like you are meeting on March 19th. And let me see. I don't want to butcher this individual's name.
Dr. Noriel.
Yes, thank you. Dr. Noriel is doing infectious disease considerations when managing a chronic foot wound.
I think this is going to be really helpful. She was rounding in the ICU today, so she couldn't come. She may be giving her talk from India, but
oh my
that's
gosh.
fine. She said she's going to do it still. But I think I'm very excited about that one. And I do want to, at that point, talk about like some of the trials. And I know Dr. Diamond, you had kind of talked about a little bit about osteomyelitis and using oral versus IV antibiotics, because that's something that's like really argued in the literature. And there's studies from England where like they say it's equally effective. And so we need to stop giving everybody IV antibiotics and PICC lines. But that study, I already know that Dr. Noriel kind of gave me extra info about that and that, oh, maybe that wasn't right. So it'll be interesting. And I think just getting, like, for you all, like, what's the right antibiotic to start these people on? That's always my question. and when I'm sending people out and things like that. So should be good. One more thing, we do send out these evaluations after every session. Please fill them out as much as you can. Stay tuned. I am going to try to send like a midterm evaluation this month to just get an idea from everyone on how they're feeling about their ability to take care of these things based on these sessions. So just kind of like how do I feel like this knowledge has helped me with my practice? So stay tuned. That's going to go out sometime in the next month. Was that what you wanted to say, Elizabeth? Or?
Yes. You did it perfectly. Yeah, we'll get that recap. Whenever you get the recap, it'll be within that recap that you're getting in that email, per usual. So if you have any questions or anything, please don't hesitate to reach out. Or if you don't get any of the emails, please reach out and we'll make sure you get that survey and the information, and the content will be there as well from today's session. We really appreciate everybody's time, and I hope you have a great rest of your week.
Thanks, everyone.
Bye.